My name is Josh Davis, and I will be observing a lower back arch through 6 main assessments. This could be a result of an alteration in available joint motion, muscle activation, and overall neuromuscular control. Our first assessment is going to be an overhead squat. The client has a lower back arch compensation, which is more visible at the lateral view. Her overactive muscles here are going to be her hip flexor complex, her erector spinae, and her latissimus dorsi. Underactive muscles would be gluteus maximus, hamstrings, and the intrinsic core stabilizers. Potential injuries associated with this are hamstring, quad, groin strains, and lower back pain. The second assessment done is a push-up assessment, done from the knees. You can see her low back sags, meaning she has an overactive erector spinae and hip flexors, and underactive intrinsic core stabilizers and glute maximus. The next assessment is a standing row. You can see her low back is arching, meaning her hip flexors and erector spinae are overactive, and her intrinsic core stabilizers are underactive. The fourth assessment is an overhead press. You can observe a low back arch. This means that she has overactive hip flexors, erector spinae, and latissimus dorsi, and underactive intrinsic core stabilizers and gluteus maximus. Our fifth assessment is a rotation test. You can see as she rotates her hands up and down, they remain far from the wall, meaning that she has overactive lats. This is not exactly due to a low back arch, which is her compensation, but since in her compensation her latissimus dorsi seem to be overactive, this is something that we might observe as we're going through the various assessments. Our sixth and final assessment is a gait assessment. You can observe a low back arch, mainly on the lateral view, as the client walks back and forth, meaning she has overactive hip flexors, erector spinae, and latissimus dorsi, and underactive gluteus maximus, core stabilizers, and hamstrings. To correct her compensation of a lower back arch, we want to start on the corrective exercise continuum, phase 1, of inhibit. This will decrease the overactivity of neuromyofascial tissue through self-myofascial release. There's evidence supporting the rationale for self-myofascial release for flexibility. It will release the microspasms that develop in traumatized tissue, break up fascial adhesions, improve tissue's ability to lengthen. We can do this multiple ways. One way is with a foam roller. The other way is with a vibration device. Since her compensation is a lower back arch and her overactive muscles are her lats, hip flexors, and erector spinae, we want to focus on those 3 muscles. The second phase of the corrective exercise continuum is lengthen. The elongation of mechanically shortened muscle and connective tissue are necessary to increase range of motion at the tissue and joint. Static stretching with low force and long duration using autogenic inhibition, holding for a minimum of 30 seconds, will decrease the muscle spindle activity and motor neuron excitability. This will allow for immediate increase in range of motion. Another form of stretching is PNF stretching, or neuromuscular stretching. Taking the muscle to its end range of motion, actively contracting the muscle for 7 to 15 seconds, and then passively moving the joint into the new end range of motion, and then holding for 20 to 30 seconds. This decreases the responsiveness of the stretch reflex and increases the tolerance to stretch. PNF has been shown to have better long-term effects on flexibility than static stretching, which is better for the short term. Here we are addressing the erector spinae. We have also focused on the hip flexors and the latissimus dorsi. The third phase of the corrective exercise continuum is activate. This deals with the stimulation and re-education of underactive myofascial tissue, which in this case is the gluteus maximus, hamstrings, and intrinsic core stabilizers. Increased intramuscular coordination through the combination of enhanced motor unit activation, synchronization, and firing rate are all known and proven to increase strength. Essentially, we want to get the underactive muscles to fire. We then move to the final phase of the corrective exercise continuum of integration. We want to re-educate the human movement system back into a functional, synergistic movement pattern by the use of multiple joint exercises to help re-establish the neuromuscular control, promoting coordinated movement among the involved muscles. This will integrate the underactive muscles back into the muscular system and hopefully correct the compensation.